So our next speaker is going to give us a little bit of a unique talk. He has no slides, and he's going to actually be presenting some information to you that may be a little bit controversial. He is the Director of Cardiac Surgery at Houston Methodist Willowbrook and Houston Methodist The Woodlands Hospitals. And he is from Louisiana, so I know he wants to go back to New Orleans. Dr. Lucas Duvall. Oh, Dr. Garami is going to have the TCD device. He's going to be talking a lot about TCD, really fascinating stuff, and he's going to have it at the welcome reception tonight, and we're going to put it on Roger while he's playing the piano and drinking to see how that affects his blood flow. No, we really are going to do this. I'm serious, not joking. And I'm also going to throw up our, after when they're doing the panel, before we take the break, I do want to talk to you all about a couple of things, show you some schedule changes, and then we'll be able to take a short break. I think we're going to be in good shape. Dr. Duvall.
Good morning. Thank you. Third time to be at the conference, second time to speak. This is a really great format and very unique, so privileged and honored to be here. So I'm going to talk a little bit about the unassuming assassin, and by that I mean how a single person can undo a complete and comprehensive blood transfusion program. Obviously, as we delve more into the science of transfusion, we scrutinize the cost of medicine and we scrutinize the outcomes of our patients. We've come to find out that everybody plays a part and an integral part. However, a single person can single-handedly undo all the hard work that you've put into place. So we'll talk a little bit about my experience. I serve with the Houston Methodist DeBakey Heart Program, Director of CV Surgery at some of the community hospitals, and I have no disclosures. So we had a couple of questions loaded up. Do we have those ready? Okay, so if we can put the questions up for the audience. So how many units of blood are transfused each year in the U.S.? 10, 15, 20, 25 million? All right, answer's going to be D. About 25 million units of products are infused in the U.S. every year, about 80 million worldwide. So you can see it's a vast part of what we do and how we take care of our patients. Next question. How many of these products do we use in cardiac surgery? 1 to 5, 5 to 10, 15 to 20, more than 20%. Goodness. Well, I guess some people transfuse more than others, but it's about 15 to 20% of the blood utilized in surgery is for cardiac surgery, and about 15% of the heart patients that receive blood receive about 80% of those products. So it really seems to revolve around some outliers, people that are having coagulopathies and bleeding for whatnot. They receive the disparate number of blood products. Next question. What is the total cost of transfusing a single unit of blood? This is kind of hard to quantify because nobody really tracks from the time the blood leaves the patient or the donor until the patient receives that blood. So there are some hidden costs, not just what the hospital pays or the hospital charges the patient for a unit of blood. So this question is a little bit misleading, but there are a lot of hidden costs, and there are estimates of $1,500 to $1,700 from the time a patient donates a unit of blood to the time a patient receives that. It involves the storage of it, the processing of it, the testing of it, etc. Okay, that's it for the questions. So a comprehensive blood utilization program carries a Class 2A indication from the Society of Thoracic Surgeons, and what that means is that it is reasonable to create a multidisciplinary blood management program, including the surgeons, perfusionists, pathologists, ICU care providers, etc. It's a reasonable means of limiting blood transfusion and decreasing perioperative bleeding while still maintaining safe outcomes. And that ultimately is what drives everything that we do, are safe, reproducible outcomes. So when I think of a multidisciplinary anything, I think it's kind of a recipe for failure. You have a lot of moving parts. You've got multiple personnel. You've got an anesthesiologist, an intensivist, a cardiologist, a surgeon, a hematopathologist, et cetera, with everybody coming at the same problem through a different prism, different background, different concepts of what transpires in the operating room. And so that can be frustrating and difficult just to simply sit down and have a cogent discussion about blood management and blood utilization. You have a lot of different equipment. We've seen a lot of evolution in the perfusion circuits, tags, point of care testing. How accurate is it? Is it reproducible? Does a point of care testing hemoglobin in the OR correlate with the value that you send off to the lab? And so there can be a lot of disconnect, and it can be hard to identify what's useful, what's unuseful, and what's misleading. And then you also have the patient, the ultimate black box. It's kind of you get what you get. You don't get to pick the patients oftentimes. It's often done in an urgent or emergent situation, and you have to take their comorbidities into account and anticipate those. Oftentimes, from kind of a behind-the-scenes administrative management standpoint, you can have some incoherent, duplicative, incongruent oversight. You have your service line levels. You have your anesthesiologist, your heart team that looks at blood utilization specifically for cardiac surgery. Then you have the surgery department level, where everybody that has a surgical procedure and is given blood gets scrutinized at that level. Hospital level, hospitals are taking this into account, and they factor cost in at this point, which can be at odds at time with the indications for blood transfusion. Then we have the system level, and then we all report to the STS. To further complicate things, you could break it down into the phase of care. Do you have, you see the patient preoperatively, do you make an intervention there? Intraoperatively, obviously, we're all comfortable with that, and then postoperatively out on the floor once they're recovering. It's important to remember also that no two hospitals are alike, no two programs are alike, and so there's obviously a lot of nuance that goes into this, and that's where I think having a multidisciplinary program comes into play, so you can have everybody gets a seat at the table and everybody's involved in the process. So at our hospital, beginning in the fourth quarter of 2014, we saw that our intraoperative blood utilization was extremely high, and this is some of our STS data. And so we started to look at it, drilled down on it, we identified some outliers, and we began to adopt more of a comprehensive blood utilization program. You could see that within about a year, we had a precipitous drop in our intraoperative blood utilization to where we were, at the end of it, below like hospitals and below the STS benchmark. Our postoperative blood utilization, however, was a little bit different. We had a couple of outliers in the first quarter of 2015. We tried to limit it. We had a slight decrease in use, but it tapered off to kind of a steady state. And so the question then became, why is this? What are we doing wrong, or how do we need to change our program to make this number better? These bar graphs show that our STS data at the end of calendar year 2016, that kind of further illustrates that we've done a good job of lowering our intraoperative blood transfusion rates to just under 24%. Postoperative blood products used, we had a decrease, but obviously not sufficient. And then our intraoperative postoperative combined rates was still too high. Now we're classified as a lower volume hospital, meaning we do less than 200 hearts per year. And so the question also becomes, how do we intervene and limit the postoperative blood products, because not every product that's transfused postoperatively was inappropriately transfused. It's how do you build a robust program and make sure you turn over every rock and stone and do everything you can preoperatively and intraoperatively to optimize your postoperative results. So in the preoperative phase, we looked at the case status. Is it elective, urgent, emergent? Preoperative lab review, we added the total iron binding capacity and ferritin levels to identify patients with iron deficient anemia. And then we want to intervene if that anemia is detected. So this becomes important when you talk about the case status, because if it's urgent or emergent, you don't really have the luxury of a lot of time to fine-tune the patient and get things set up for a good result intraoperatively and postoperatively. I can tell you at our institution, we probably didn't pay enough due diligence to the preoperative lab review. We pretty much checked that off as a box. It was a requirement to have fresh labs, and so if they had them, great, then we'll go do the surgery. And so I would say that the assassin in this situation is going to be the surgeon, the cardiologist, and the anesthesiologist. We're the ones that are primarily responsible to getting the patient to this point for surgery, and obviously the ones in the best situation or position to intervene if necessary. The case status often also depends on the cardiologist, who you're getting the patients from. There are some mores and norms and personality attributes that come into play here, practice patterns of cardiologists and what they're comfortable doing, sending patients home, putting them in the hospital and sitting on them until they get surgery, et cetera. And so it's not just as simple as altering a lab value or making the patient a elective procedure rather than an emergent or urgent procedure. And then this is a review of the status of our cases. So in 2014, 2015, and 2016, we had roughly 65%, 58%, and 73% of our cases were deemed urgent or emergent versus 62% in like groups. So we were certainly an outlier in classifying our cases, and there's obviously room for improvement there. Statistically, we're at a higher risk of transfusion just based upon our case status. The STS in 2011 identified 3 major factors within blood programs that increased your risk of transfusion. One of them was complicated or complex procedure. The other one was patients over 70. And the last one is the preoperative anemia and the urgency of the case. So just by simply converting as many urgent cases to elective, we should see a decrease in our blood utilization just because the risk is decreased. To better bolster that is if you look at preoperative anticoagulants. I think everybody today is on some sort of anticoagulant, whether we know it or not. Our data at our hospital ended in 2016 showed that roughly 58% of our patients were on some sort of anticoagulant or antithrombotic therapy prior to their heart surgery. And then when you have your patients in an urgent or emergent case status, it's oftentimes difficult to reverse that, allow the half-life of the drug to wear off to where it's not an issue intraoperatively and postoperatively. So all these things you kind of start to figure out play on each other, and it really requires a robust program to identify these things and enact changes. Intraoperatively, this is easy. I mean, there are no assassins. This is our safe space. You know, we could all be snowflakes and happy in the OR because everybody knows each other. You have your surgeon, you have your perfusionist, and you have your anesthesiologist, and everybody's talking, interacting, and everybody knows what's going on. We adopted a loose transfusion guideline. They had to be a hemoglobin less than 6, crit less than 18, and some evidence of end-organ malperfusion. There obviously are other adjuncts that you can use as well, lactate levels, and urine output, et cetera, as well as your Swan GANs or your flow track numbers to help better fine-tune your decision-making process. So this was our safe space. So we did a very good job, and the data shows that we were below the STS benchmark for intraoperative blood utilization. Postoperatively, this is finding a killer in the crowded room. This is that scene in Jason Bourne where he gets a headshot from across the room from an air duct. And nobody knows what happened, what's going on, where did it come from. And so we adopted a rough guideline postoperatively for transfusion. It had to be hemoglobin 7, 20, crit 21. And again, really just some indicators of end-organ malperfusion. A lot of different cooks in the kitchen at this point. You have your primary care doctors, your hospitalists, nephrologists, GI guys, et cetera. And so everybody has their own prism that they're judging anemia from, and you can't assume that their background is the same as yours and that they understand what patients can and cannot tolerate. And therefore, their perspective is skewed, and we felt that postoperatively, this is probably where we had some of our fallout from the STS. So to go back and review, we kind of tapered off, and we felt like we found out why. We did not have a good significant improvement since the spring of 2015. And we felt that it was probably people outside the heart team that was ordering blood. So then we established the CV ordering group. So it consisted of the intensivist, the cardiologist, and the surgeon. We felt that it was to the point that patients should not receive blood unless they get the authorization or the okay from one of those three people. And oftentimes the whole team would be notified prior to that happening. So in July and August of 2015, we had a fair number of non-heart team physicians ordering blood products. It's a bit of a cultural change. You do get some pushback, but I think that when you're transparent with your data and you have everybody at the table on your blood management program team, then you start to get some buy-in, but it does take a little bit of time. In 2016, we did a great job, hardly anybody. And keep in mind that this is a low-volume program, less than 200 hearts, so any outliers are going to show up and have statistical significance. And then in 2017, again, we've been doing very well. So were they really outside assassins? You saw that our postoperative transfusion graph tapered off and was basically in a steady state. In 2015, we had 13 patients transfused by non-heart team members, dropped to 10 in 2016, and we only had 1 in calendar year 2017. So even though we thought that we had identified the assassin, the nephrologist, GI, primary care, etc., it really wasn't supported by the data. So just to summarize what this is again showing our thing. Virtually, we've eliminated all non-CV team blood transfusions in our program. However, we are still not where we want to be. So the summary is obviously the heart team's the assassin. We were not doing our due diligence post-operatively, not managing the patient properly preoperatively, and doing some small things. You gain 1 or 2% here, 1 less blood product on this patient there. It starts to add up, especially when you have a lower volume program. So a comprehensive utilization program does not succeed without buy-in from all members of the patient care organization, integration, acceptance by those personnel, and you have to interact on a frequent basis. We found that we overlooked probably some preoperative things, and then we're in the process of reviewing that data and seeing which patients were anemic, were they on antithrombotics or anticoagulants, and did they receive blood products to better fine-tune our preoperative phase of care. And non-transfusion interventions were underutilized at our hospital as well. Oral iron supplementation, erythropoietin use, etc. And then persistent review of the institution-specific data. It's not really sexy work, but it certainly can be effective. And when you have complete buy-in, I think that if we do this talk again next year, it will probably show that our postoperative rates are significantly decreased. With that, that's it.